Hello, my name is Jeremy with Faithful Guardian Training Center. Today we're going to be talking about EMS systems. The big thing about EMS systems is we're getting into scope of practice, medical control, the CQI process, and things like that. To start off with, something that a lot of people get confused about is scope of practice. Scope of practice is what you're allowed to do at your specified licensure or certification level. Certification is what allows you to actually get licensed to be at that level. For example, a EMT can act as a EMT once they obtain their certification through National Registry, and after they obtain that certification, they apply to the state for their EMT licensure. Now, if you have somebody who is an advanced EMT, who is a certified and a licensed advanced EMT, who goes to paramedic school and graduates, completes National Registry, and gets certified as a paramedic, their licensure is still going to reflect advanced EMT until they upgrade their license. Right? And that's part of that scope of practice. That license is what you're allowed to practice as. That certification shows that you have the knowledge available and the skills available where you can perform to that level. But as far as your medical director is concerned, as far as your state is concerned, you are still only allowed to act up to the advanced EMT level in that example. Something that EMTs can do is, and these are the old basic EMTs, so it's just a regular EMT. It's not an advanced EMT. It's not a paramedic. It's an EMT, emergency medical technician. They can insert OPAs and NPAs. They can check vital signs. They can assist patients in administering their medications. This includes an EpiPen. This includes nitro. Those types of things that we'll use in the emergency setting. And they are allowed to perform spinal immobilization and perform CPR. Now, whenever you get to an advanced EMT, this is whenever you're getting into what is considered the ALS skills, or the advanced life support skills. An AEMT can insert a supraglottic airway, which is where you have where you take an airway device and you insert it where it's never going to insert through the vocal cords or through the larynx. It is going to lie at the glottic area, and it may lift the tongue up, and you may have this bulb that gets into the esophagus to kind of occlude the esophagus. There's multiple different types. You have a king airway, a combi tube, eye gels, cobras, and other LMAs or laryngeal mask airways. Now there's multiple different types, but that is one big difference between an EMT and an advanced EMT. Advanced EMTs are also trained to be able to perform IVs and IOs, or intravenous access and intraosseous access. And they can give medications through those IVs and through those IOs. The medications that an advanced EMT can give intravenous include normal saline, lactated ringers, D5, D10, the basic crystalloid solutions. And then they are also allowed to give Narcan intravenous or intraosseous, and they can also give D50 intravenous or intraosseous. And those are the only drugs per the national curriculum that they're allowed to give those routes. There's other medications that they can give via nebulizer, sub-Q, intramuscular, sublingual, and so medication they can give sublingual would be nitro, for example. Nebulized, an advanced EMT can give albuterol. And then IM or sub-Q, you can give glucagon, you can give epinephrine for anaphylactic reactions. And there's a couple more medications, but we can talk about those in a later video. And an advanced EMT can also do everything that an EMT can do, because their certification level and their licensure level is greater than what the EMT has. And then you get into paramedics. Paramedics are able to perform laryngoscopy, where you actually take a laryngoscope and you will actually lift up the tongue, possibly lift up the epiglottis, and visualize the vocal cords, and you are allowed to pass a endotracheal tube through those cords to secure an airway for your patient who's not breathing. You're also allowed to manually defibrillate using a cardiac monitor. You can pace, you can push lots more medications than an advanced EMT can. Needle decompression for people who have pneumothoraxes or tension pneumothoraxes. There's greater ventilator training for transfers or for putting a patient on the ventilator on scene. And those are the really big things that a paramedic can do that an advanced EMT cannot. And the thing about scope of practice is you need to know the scope of practice of the person above you and below you. That way you know who and how they can adequately most deliver the more appropriate care versus what you can do. Now, getting into that, we also have medical control. And so that also includes your medical director. Your medical director, that is the person who approves what you're allowed to do in the field. So for example, let's say that you work for a service where your medical director has allowed you as an advanced EMT to perform supraglottic airways and IVs, but you're not allowed to administer D50 to somebody intravenous. Well, that is something that's going to be based off your local protocols. And so your medical director, they have the ability to add a couple things or take away as much as they like depending on what state that they're in. Then you have medical control. There's two real big types of medical control. You have online and offline medical control. Online medical control is when you are directly speaking to a physician, whether it be through a phone, a radio, or even a video, where you are seeing or you're in real time speaking to a physician who is going through procedures for you to do. Now, the online medical control includes, again, radio, telephone, and all when you're talking directly to a physician. They may teach you how to do things or guide you through things over the radio that you would not typically do. But at the end of the day, that's going to fall on that medical control or that physician that you're speaking with. And so you kind of have to let your conscience be your guide and make the best sound judgment that you can when speaking to the physician over the radio, because it's not face to face. And a good way to do that is whenever they say an order over the radio, such as go ahead and give another 0.4 milligrams sublingual of nitro, you repeat back to them, you want me to give them another 0.4 milligrams of nitro sublingual. You want to repeat it back to them exactly what it is that they understood. That way they can confirm or deny the order that they just gave. So for example, if they say, if you heard in that exact same scenario, give 4 milligrams of nitro sublingual, well, you should know that 4 milligrams includes 10 tablets or 10 sprays. And that's a lot, and that could put your patient in very high risk if you perform that treatment. And so you need to say, you want me to give my patient 4 milligrams of nitroglycerin sublingual? And if that physician comes back yes, they may have misheard you as well. And if it does not sit well with you, you have the ability and the option to not follow that order in the field until you get to the hospital if it's something that you're not comfortable with. And you stay within your scope of practice and you get your patient to the hospital. Because at the end of the day, that's what we do. Offline medical control, that is going to be your standing orders, your protocols, and your training that your medical director is going to perform, or people that your medical director has deemed competent and qualified enough to come and do your training. So for example, if you are running a call and it's a asthma attack, well, you need to know what your local service does for an asthma attack. And you will have this book of protocols. That book of protocols, you open it up and it's going to tell you everything that you need to do for your patient that your medical director has approved. And that's an example of the offline medical control. You are never speaking to a physician. You're going off of a written document or your knowledge from the training that you've had before. Should you deviate from that care, that's when you're going to have some explaining to do to your medical director. Who again, your medical director is the person who authorizes you to provide medical care in the field. They authorize you as an EMT, they authorize you as an advanced EMT, and they authorize you as a paramedic to perform up to that level because they know what you're capable of. A lot of services, and it's becoming an industry standard, is they're implementing this continuous quality improvement, or CQI. It's a QA type program where they are quality assurance, where they are reviewing your paperwork or your PCRs, patient care reports, electronic health reports, EHRs, whatever it is that your service is doing. They're reviewing it, they're going over it to see if you breached protocol, to see if you could have done something a little better, or maybe the protocol needs to be rewritten because it's not clearly understood. It's something that's not about to throw anybody under the bus. It's not out there to make anybody feel incompetent. It's out there to constantly be improving medicine as we practice it, and that's why physicians, they practice medicine, because it's an evolving door. It's always changing. And something else we get into is primary prevention and secondary prevention, and this is going to refer to your patients and what they're going through. So, for example, primary prevention focuses on strategies that will prevent an event from ever happening. For example, vaccines, the polio vaccine, smallpox vaccine, chickenpox, all those are designed to prevent the person that receives that vaccine from ever getting that disease. And so it is completely eradicating the chances of that event happening, is the goal of the primary prevention. Secondary prevention is the event has already happened and the damage needs to be minimized. So, for example, we cannot stop people from getting in car crashes aside from training and stuff like that, but car crashes are still going to happen. There's always going to be that human error. Some examples of the secondary prevention, that's going to include helmets and guardrails. They do not prevent the event, they just prevent it from being worse. So, for example, the way that a helmet will help is if you fall over on your bicycle or your motorcycle and you land on your head, instead of cracking your skull open, your helmet gets cracked open. You may still have neck or spine injuries associated with the injury, but your cranium is going to be mostly intact. Guardrails, for example, if you're on a mountain and you don't have guardrails and you drive over the road, you go straight down the mountain and there's not much anybody can do for you at that point. And that gets into complicated rescue efforts. The guardrail, you run into the guardrail, it is hopefully going to prevent you from going over the mountain. It doesn't prevent the accident from happening, it just prevents it from getting worse. And that's the really big thing to go over right there. And those are the big things that EMS systems do, because as an EMS system, we'll help implement and provide the knowledge of the primary and secondary preventions. And that's it about EMS systems.